One is minimally invasive with any, almost it's the same surgery, but the incisions are smaller. So as a result of small incision, you recover faster. And the most important thing is that they should have at least an equivalent or a better long-term outcome when you're dealing with, the overall long-term follow-up. So what we do is we do osteotomies and fusion, and why minimally invasive have never been famous before, because of the fact that the drills that we use, if we cut the bone and we shift the bone, um, they normally, because of the high speed involved, you will basically cause heat necrosis, and then that heat necrosis will not allow it to heal well. So what we have, or what was the latest development was that there is a high torque and low speed burst system which has been developed, which reduces the extent of the heat necrosis and thence avoids non-union. And you see that when you're doing a minimally invasive hallux valgus surgery, you are actually translating it to a significant extent by more than 100%. But because it is low speed, so it kind of helps in making the bone form again. So this is the problem with the open surgery. Why we do go for minimally invasive surgeries is because we have these long cuts when you're doing open surgery. This is one of the patient in which we fixed three toes, and this is what you get, and you're always worried about the wound healing and dehiscence when you're doing multiple toe surgeries. So definitely, apart from the wound issues, these patients develop stiffness as well because you're not very aggressive in their mobilization and multiple incisions. And obviously, the time taken is a lot because then you have to do a closure also, which would take further time. So, is minimally invasive surgery new? Actually, not. It was established way back in the year 1945. But at that point of time, because of the lack of technical development and publications, it was not really popularized. And this man, Dr. Polakov, was the one who, first of all, established the concept of minimally invasive surgery in the foot and ankle region. It was then popularized in 1980s by Dr. Isham, and finally in 2002, under the aegis of a research group and study in minimally invasive surgery of the foot, which is GRESMIP, this has become more popular, and now we are here where we are today. What are the minimally invasive surgeries that we can do in foot and ankle surgery? The most common is definitely a hallux valgus osteotomy, which is a metatarsal osteotomy or an Aiken osteotomy. We can do calcaneal osteotomy, which can be either a sliding or a device osteotomy. For the lesser metatarsal, there is an osteotomy called as distal metatarsal minimally invasive osteotomy, or what we call as DMMO. Then for bunion net, Taylor's bunion, you can do osteotomy of the fifth metatarsal by minimally invasive technique. Uh, and then lately, something which has become very popular is a Zadek's osteotomy, which is basically a dorsal closing wedge osteotomy of, for the Achilles tendinopathy, dorsal closing wedge osteotomy of the calcaneum. This can also be done in a minimally invasive fashion. And then we have fusions like first MTPJ fusion and Lapidus fusion. This also, as you grow more experience, you can start doing these fusions, and not just MTP, but interphalangeal joint fusion also can be done using minimally invasive surgery. And then as you grow further, you can do TMTJ fusion, NCJ fusion, and hindfoot fusion as well. And it has a significant role in management of Charcot's arthropathy as well. So talking about the osteotomy, there are four generations of the hallux valgus or osteotomies. I mean, now they are even talking about fifth generation as well, but I think it's more of a marketing technique rather than really a significant shift in the osteotomy. So first generation was popularized by Isham, and it was a modification of Reverdin. So basically, there was this Riverdin osteotomy which was done way back in 19th century, in which you are doing a closing intra-articular closing wedge or an incomplete osteotomy, which is slightly oblique for the first metatarsal head, and then it would improve the hallux valgus angle. But it because it being a distal osteotomy, it doesn't really correct the intermetatarsal angle, and most of the times it is unfixed, so you're not really using any kind of fixation. So obviously you can see that this is the first osteotomy which was done using minimally invasive technique, and it is something which is still done as an outpatient osteotomy. So you just do a closing wedge osteotomy without anything, just put a local and then just do it and let the patient go back. And it's still done in various parts of the world. But because it is not a very strong osteotomy and it doesn't correct the IM angle, so it still does not correct everything. And complications are quite high, almost 30%. And because of the fact that it's an intra-articular osteotomy, so there is a risk of loss of movement and stiffness in the metatarsophalangeal joint as well. Then came the next generation, which was an osteotomy, and along with that, you do a shifting of the bone, and then fix it temporarily with the help of K-wire, which was popularized by Bosch, and it was a modification of Hoffman osteotomy. And another technique is simple, effective, rapid, and inexpensive, which is SERI technique. This is something that if you really are short of funds, then you can do that also. So Bosch was something which was done with the help of a burr, and Seri is described based upon the use of oscillating saw. To just shift it and then put a K wire intramedullary into the first metatarsal, and that actually K wire actually serves as a translational support which maintains the translation of the distal metatarsal head as well as the phalanx. And as you can see on the image over here, uh, as you can see on the image over here, you can do the osteotomy in different planes. So you can do it slightly oblique, which is curved proximally so as to shorten the ray, or you can make it transfer, or you can do it oblique distally to lengthen the ray. And then at the same time, you can planterize it or you can dorsiflex it if you want to refunction or defunction the first metatarsal, depending upon the extent of the metatarsalgia that the patient has. But the problem with this was because it is still an unfixed kind of an osteotomy and it's a complete displacement. So there is a high risk of dorsal or plantar displacement because you have to really prevent the movement happening. It's not a stable osteotomy. So the stiffness in the metatarsophalangeal and interphalangeal joint is something that develops. And because you're using a pin, so there is a risk of pin tract infection. And it being not very strong, there is always a risk of recurrence in these cases as well. So then the third generation is something which really shifted the tide towards the successful minimally invasive surgery. It is called as PECA, which is percutaneous chevron and Aiken osteotomy. So you're doing a simple chevron osteotomy only, which is basically a V-shaped osteotomy. And then you're shifting the capital fragment or the metatarsal head fragment laterally, and then you're fixing it with screws. If you look at it, it's a very, you're shifting it and then you're fixing it with the screw. There is no dorsal or plantar displacement happening. It is a very stable osteotomy. But the main problem is it still fails to correct something called as pronation, because most of these patients do have a component of pronation of the metatarsal head in these cases. And when you're doing a shifting, you're not really correcting the pronation, though, despite the fact that the osteotomy is very stable, but rotation is something which is difficult to cut, difficult to correct in these cases. And as a result, the pronation may sometimes persist in these cases. But this is something which has paved way for what is the current status of osteoarthritis, and this has a significantly lower, complication and a recurrence rate. So similarly, the fourth generation is something which has now developed, which is not a chevron Aiken, but more of a transverse osteotomy. So when you're doing a transverse osteotomy, you're able to correct the pronation better because then you can derotate the metatarsal head, which could help in stabilizing or improving the pronation. And then you stabilize it with the help of two screws. So you can use this specialized jig, which is also available. So that can also be used in these cases. Okay, so talking about the technique of these osteotomies, so incision is normally given with something called as a beaver blade, which is a specialized blade for metatarsal for hallux valgus or MIS surgery for that matter, and it can be between 1 to 3 millimeter. The incision in the initial time is given mostly under the C-arm guidance. When you're using the burrs, you're using a 2 by 19.5 millimeter straight burr for the metatarsal osteotomy. For Aiken, you do a 2 by 39 millimeter burr. You're using a AR200 drill system, which is from the Arthrex, which I have. And most important is it is high torque. It has a good strength so that it can cut the bone, but it is still working at a low speed. You can go as low as 500 or 5,000 or 4,000 RPM as well, but the standard speed that I'm using is 6,000 RPM. You may or may not use an MIS jig. It depends upon your training, your experience, as well as the availability of the jig as well. The for fixation, you're using headless screws, so it can be a beveled or a non-beveled, again based upon availability and the cost as well. So this is just an example of a patient who has a hallux valgus. So you can see that the angle is 31 degrees and 25 degrees at pain under the bunion. So, such cases, if we look at it, this patient is a young female. If we draw an angle along the medial cuneiform and along the metatarsal, we can see that this patient also happens to have something called as metatarsus adductus as well. And when you have metatarsus adductus along with that, so you see that the intermetatarsal angle is not significantly widened, and you do not have a lot of space to push the metatarsal away. So in those cases, it is advisable to do a osteotomy or to correct the metatarsus adductus as well. And the classical cases, what we were doing in the previous times was that we do an open osteotomy. So basically, open it from here, do a transverse or an oblique, basically proximal metatarsal osteotomy, and then shift it laterally to improve the metatarsus adductors. But what we do now is a distal DMMO, which is distal osteotomy of the metatarsal. So to do it slightly more at the proximal area. So this is where the DMMO is being done. So all three bones are cut, and then you'd make a cut using the beaver blade or a normal size 15 or size 11 blade. Use a specialized periosteum elevator, and elevate the periosteum so that you can feel the bone. And then osteotomy is done using the burr at this level of the metatarsal neck. You can go slightly more distal as well, but it should be proximal to the level of the sesamoid. Angle, as I said, can be changed according to need of shortening and lengthening. So if you want to lengthen it, you will angle it more distally. If you want to shorten it, you will angle it more proximally. So what I always do is cut one portion and then I look at my direction, and then I do pierce the second cortex. And once you do a second cortex, then you need the help of minimally invasive, but you go proximally and you go distally. You can do a straight or a chevron cut. We normally do a straight cuts now to improve the pronation as well. Once the whole bone is cut, then the metatarsal head is shifted or pushed laterally. And when you are shifting it laterally, you see that this actually tends to tilt as well. So you are supposed to hold the metatarsal, hold the toe, and so that this tilt does not happen, and it laterally does not get angulated. And if the pronation is to be corrected, you have to correct the pronation as well. And then followed by that, you put two guide wires like this from the base of the metatarsals to the head. And as you can see over here, this is the area that when you are actually exiting out, there should be some bone over here. So basically, the more proximal screw has one cortex, second cortex to breach, so two cortex, and then into the metatarsal head, while the second or the more distal screw is most of the time an intramedullary and mostly for the support. Check this when you have fixed it, you check all the three views, AP, oblique, as well as lateral, because many a times you would see that everything looks okay, but in lateral it has gone more dorsal, more plantar, or the metacapital fragment has shifted dorsally or laterally or plantarly as well. Then you fix it with one or two headless screws, depending upon Again, the quality of the bone. So even one screw is sufficient if it is a beveled screw designed for the hallux. Um, Normally, what I do is I put two 4 mm screw, but you can put one 4 mm and one 3.5 mm as well. Once you do that, so you can see that where this phalanx is. So this basically becomes something like this may become prominent. This would be painful to the patient. So in we have to remove this. So we cut it using the burr. It some people called it this medial bump as a love triangle because it's a triangular piece of bone that is basically removed after that. And if after that, if you feel the need, then you can do an Aiken osteotomy if clinically indicated. You can do either only the medial cortex, or many a times I actually prefer to go bicortical when we need a lot of correction. Because as you can see in this has gone bicortical and is shifted. But because it is minimally invasive, I've never seen any non-union in Aiken. And then you can fix it with 3.5 or 2.5 mm headless compression screws. If you have done unicortical, then you can even leave it without fixation, and you can just change it. You can improve it by doing bandages as well. So this is how it goes. Always check the lateral view. So you see on the lateral view, your metatarsal head should always be in the line with the shaft, and then your screw should ideally be center. So in an ideal world, you should actually see one screw only in the AP, and you have to make sure that the screw is not going dorsally or plantarly. I've done that, so I know it can happen. Okay, and this is how the preoperative and the postoperative X-ray is. And this is the clinical picture. As you can see, this patient had a DMMO as well. And these are the extent of the cuts. And for DMMO, you can see it's just very small cuts. Post-operative, we allow weight bearing depending upon the quality of the bone, either in the boot or in the shoe the next day. When you're doing a distal metatarsal osteotomy, because it is an unfixed osteotomy, so you want the patient to stand and weight bear so that the osteotomy can actually take its own position. So this is another patient. So if you have uh, you know, if you have first TMTJ instability, you can do a Lapidus fusion. That is what is recommended, which is the fusion of the first tarsometatarsal joint. And this can also be done in a minimally invasive technique. You do a Lapidus as well as Aiken osteotomy like in this. So this is just a picture, and this is the clinical picture, as you can see. This is just a drawing to show the first TMT joint, the periosteal elevator that is being used. And then this is the small cut through which we are doing actually preparation of the joint. So we have put the burr inside, and now you can see that I'm actually at the first tarsometatarsal joint. This is the joint preparation which is happening. So now understand that it is an increased intermetatarsal angle. So what you need to do is you need to remove the more bone from the lateral side than from the medial side. It's more of so what we're doing is this kind of a lateral closing wedge osteotomy. So we remove more bone from here, and with the help of burr, you just burr a little bit more so that the area has a tendency to get compressed. So you see that we just angulated so that we can just angulate it so that we remove more bone, and then we just correct the intermetatarsal angle and then fix it with two screws. Then you do an MIS bunionectomy, and followed by this is for the Aiken. So you can see that the burr has actually entered inside into the proximal phalanx. You can see this is more of an oblique osteotomy. So the idea of doing an oblique osteotomy is you plan to fix the screw from here to here. Then you can do just in the oblique osteotomy, your screw would be perpendicular, so then oblique is better. So you see this is we have opened. It's basically the lateral cortex is left intact, the medial cortex is actually opened up, and then you just compress it and then you fix it. This is the final picture of doing the lapidus, and these are the small cuts. So you can do these procedures also using arthroscopy. This is another patient, so another example of how you can help these patients with minimally invasive surgery. So you have a hallux valgus, and the main problem is the pronation of the big toe. So the big toe is getting pronated, and this man who's a patient, he has this ulcer, for many years. So it is there, and he has been working on this, and because of the biomechanical problem that he's putting more pressure on the medial aspect of the big toe, so his ulcer is not healing. So this is just another video. As you can see that the big toe has gone into pronation. So if you look at the line of the nail, you can see the extent of the big toe pronation as compared to the normal nail. And because of that, there is an increased pressure on the medial aspect of the big toe. Again, the patient is diabetic, minimal sensations. So then so a very mild hallux valgus is what he has. So what was done in this case was a minimally invasive surgery. Again, a closing wedge osteotomy along with the derotation. So normally when you're doing an osteotomy, you're basically removing more of the medial aspect, and you're not really preserve. You're trying to avoid going and breaching the lateral cortex in these cases. But when you're doing a derotation osteotomy, what you have to do is you basically have to remove, or you have to go bicortical. So in this case, what you normally do is this is the minimally invasive lapidus and Aiken osteotomy. So in cases with the TMTJ instability, you do this kind of procedure. Um, so this is how it is basically. This is what we have done is we have marked the tarsometatarsal articulation and this on the using C-arm guidance. So this is the periosteum elevator that we use to elevate the periosteum. And then this is the burr which is inserted for joint. And as you can see that this is what we're preparing the joint. Now, when we're doing a lapidus, what we are trying to do is we are trying to reduce the intermetatarsal angle. So basically, you're trying to close the joint on the, kind of doing a lateral closing wedge osteotomy. So what you need to do is you need to remove more bone on the lateral side when you're doing it. So you can see that we are budding the bone from the lateral aspect. So then this is the correction of the IMA, and then we fix it with screws, two screws, do a MIS bunionectomy, and then this is for the Aiken. So you basically do a small cut into proximal phalanx. This is how it is basically. So the direction is a bit oblique because when you're fixing the screw, it becomes really, really tricky to have a screw which is actually projecting like this in the minimally invasive way because the wires are very flimsy. So even if your screw is somewhere exiting around here, so that also works well. So you can see open this basically closing wedge. So we removed a bit of wedge of bone. And then this is the final picture. And this is the corrected position. So this is another with the Hallux valgus, diabetic patient with big toe pronation, and due to the biomechanical problem, because of pronation, he had this chronic wound on the big toe just under the proximal phalanx. The main reason is the patient is neuropathic, has diabetes, and is overloading this area, and he's not really feeling it and continues to walk, and he has this long-standing ulcer. So again, diabetic patient. So if you do any kind of corrective surgery, there is a high risk of complication in the toes because of the poor vascularity and the increased chance of infection in diabetic patient. So you can see, as you can see, there's a big toe pronation. You can see the direction of the nail. It is slightly an angle as compared to the other toenails. And he has a very mild hallux valgus. So the idea was not correcting the hallux valgus. So in this, you do a closing wedge and derotation osteotomy. So what you do is you do a closing wedge osteotomy initially like an Aiken to improve the intermetatarsal angle. So this is basically what you do is you remove more bone or wedge from the medial side. Don't yeah. So anyways, and if you look at these incision basically, so I think I'll just tell about the osteotomy. So basically, When you're doing a closing wedge and derotation osteotomy, you're actually removing a bit of bone from the medial side, and then you're going all the way to the and you're piercing this cortex on the lateral side after that, so that you basically do a closing wedge as well as rotate the osteotomy. And so you can see that these are the small cuts. So this really is an MIS surgery. So basically, you're not really causing any risk of damage to the blood vessel supply.
Right. So,
Yes.
anyways, so we're just talking about that when we go further ahead, we can even do some grotesque deformities also and correct it by MIS. The advantage again, small incision, you can do multiple things at one go. So, like in this patient, she had a hammer toe of third, crossover toe of second, and the first toe is also there's a significant hallux valgus. So with small cuts, we did a distal metatarsal osteotomy of the third, which was more than sufficient. We did the same thing for the second. Did using this incision, we did an extensor tendon release. Then we did an interphalangeal joint fusion using a small cut over here, PIPJ fusion. Despite everything, it was still not fully corrected. So what we did was we did a osteotomy of the proximal phalanx as well. The wire was inserted mainly for the IPJ fusion. Otherwise, we don't really we don't really put wires. And then the remaining was for the phalangeal osteotomy. And you can see that this is a little bit open. It is significant. It looks quite bad, but because it's MIS, so actually it will all heal up very well. Another patient with an inflammatory cock-up toe deformity in a patient with rheumatoid arthritis. As you can see on this X-ray, there is an end-on view for the proximal phalanx because it is dislocated by 90 degrees almost. And this has been chronic, so you're obviously suspecting some kind of wound issues that might develop in this case. If you do any kind of open surgery, already blood supply is very tenuous in the toes. So what we did was the plan was to do an interphalangeal joint fusion. So
Okay.
anyway, so this patient basically had a chronic deformity, and we know that we are dealing with something which is quite grotesque. And if you do an open surgery, you might be dealing with some wound-related complication. So what we did was we use a bigger, burr in this case, like a 3 millimeter burr, to shorten the phalanx basically. So we cut the phalanx and we shortened it first of all because we need to really bring it together, and then small burr to remove all the bones and complete the fusion. So basically clear off the proximal and the distal phalanx all. Then the patient also had, if you can see on this X-ray, the patient's toe is really bent. So we did an osteotomy of the proximal phalanx in these cases as well, and then finally fix it with the screw. And this is what the picture looks like. So you can see over here, this small cut over here, and then one cut to put the screw over here, and that's about it. And there are very tiny cuts for the proximal phalangeal osteotomy. That's about it.